Rewari sir, is it okay if I share my screen till pre-test?
Meanwhile, I don't think there will be any problem in that. You may ask.
Yes, sir.
That will save some time.
Yes, sir. Kiran sir, can we start the recording, please? Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar Series. We are disseminating the National Guidelines for HIV Care and Treatment 2021. Today's topic is ART treatment failure in adults and adolescents, when and what to switch. Speakers are Dr. A.K. Puri sir from NACO, Dr. Rewari sir from WHO SEARO, and Dr. Anwar Parvez sir from Department of Global Health, University of Washington. We welcome you all for today's session. I now request Dr. Puri sir to please give the opening remarks.
Good afternoon, everybody. All the ART centers, all the participants, speakers, Dr. Anwar, Dr. Rewari, iTech India, NACO team, everybody, thanks for joining this session. It is a very important session as it has already been indicated. As you know that plasma viral load is recommended as a preferred monitoring approach. Why it is preferred? Because it is more sensitive, it is more specific for the as compared to the immunological and clinical mode of finding out whether the treatment person is going on the failure. Because the viral by way of viral diagnosis, we will be able to find out earlier as compared to the clinical and the immunological failure. So we'll be able to prevent the what you call failure in many cases. It has been seen that 70% of the cases, if the adherence is done properly, then the treatment failure can be prevented. So if the person is having viral load and at an initial stage, if we are able to tell him to adhere to the ART at that very time, and if he listen to our advice, he will be benefited through this intervention only. So this is how the viral load is more helpful, as especially for the whenever we are taking the other this thing. Switching to the other medicines like to the from first line to second line also, viral load is also more important. So we will also be discussing in a brief about the viral load testing algorithm, step up adherence in the patient with the non-adherence and suspected treatment failure. Treatment failure to the first line and second line ART substitutions versus a switch recommended ART regime for the patient failed in the first line ART. Steps in the initiating second line ART and comprehensive second line ART regime for PLHIV failing on first line ART. Various scenarios of initiation of third line ART. Initiation of PI-based ART in the patients already on anti-TB treatment. Management of side effects along with drugs interaction related to the second and third line regime. And now I request my colleagues, Dr. B.B. Rewari and Dr. Anwar Parvez Sayed to brief on these subjects. Thank you. Thank you all. Please listen to this topic. It is very important and interesting.
Thank you so much, sir. Kiran, can we quickly run the pre-test, please? Participants are requested to please attempt the pre-test that is visible on their screens now. There are 5 questions in all. The first 3 questions and the 5th question, they are single choice answers. For the 4th question, it's a multiple choice answer. We have 2 minutes for the pre-test. Praveen sir, can you please confirm how many have attempted till now?
It is just 4 out of 150.
Participants are requested to please make this quick. Requesting all participants to please attempt the pre-test. Praveen sir, we can end the e-poll now. I now request Rewari sir to please continue the session. Sir, you'll have to share the screen.
Can you see my screen?
Yes, sir.
So good afternoon, everyone. And I would like to thank NACO for giving me this opportunity to present this NDLS on ART treatment failure. More than that, I would also like to congratulate NACO on taking this initiative of revising the antiretroviral treatment guidelines, both technical and operational, supported by a number of partners like CDC, WHO, ITEC, and ITEC for carrying this series of NDLS. And we had advanced disease management, first line ART toxicities, and now ARV treatment failure in adult and adolescents. So we'll be discussing basically when and what to switch. So this session is around following points. That is, we'll see how a person responds to antiretroviral therapy once it is initiated, and then what time we say he's failing on a treatment. We'll also see what are the guidelines on viral load testing, adherence support, treatment failure, and what regimen to use in second line. And if there is a second line failure, what regimen to use in third line. We'll also go through briefly drug-drug interactions with key ARV drugs, though this has already been covered in one of the NDLS, I think, last time. This is just a recap from the previous sessions. And if you really look at this, this shows you a HIV replication cycle. And if you see, as soon as the virus gets attached to CD4 cell and enters the CD4 cell, facilitated by CCRS and CCR5 and CXR-CR4 receptors, it actually sheds its RNA in the CD4 cell, which undergoes a reverse transcription to DNA. You're all aware of this, but just for recapping. And this DNA then gets integrated into the host DNA, facilitated by an enzyme called integrase. And then there is a transcription and budding out of the virus after facilitation of protein cleavage by protease inhibitors. And basically, this cycle also depicts the various sites of action of antiretroviral drugs, because they might act at the stage of fusion of the virus with the CD4 cell. They might block the enzyme reverse transcriptase or integrase or protease, and then they may also be basically CCR5 receptor antagonist acting at various stages. And you know that every day almost 1 billion viruses are produced in replication. And because of its potential to escape some of the steps, it is very important that we use this blocking of the virus replication and multiple steps using at least 3 antiretroviral drugs. And this, you all are very well aware about the groups of the drugs, which include nucleoside reverse transcriptase inhibitors, nucleotide reverse transcriptase inhibitor, which include both TDF and TAF, though TAF is still not in the program. Then non-nucleoside reverse transcriptase inhibitors, which are gradually being phased out with more potential, and integrase inhibitors, which have got higher potential for suppression of virus and very little chances of resistance. And there are some other groups of drugs also, protease inhibitors, which we have been using, and you're quite familiar with them. And some of the newer drugs, basically, which are in the pipeline, but I'll not go through details of those. Basic recommended regimen, we all know that this is the regimen recommended by NACO, and that is a DTG containing regimen is the preferred first line. And this was basically rolled out 2 years ago. We are in July 2022 now, and in 2020, basically this guidance came that we have to move to DTG as first line. And I think you all know the evidence behind it. I will not go into details, but just to highlight that DTG came in because of various reasons, and evidence from the single study and other studies which basically showed that viral suppression with DTG is quite fast, taking just 28 days compared to 84 days with efavirenz. the viral suppression is faster and CD4 count increase is also higher. Also, the toxicity related to DTG is much less than that related to efavirenz, 2% compared to 12% with efavirenz, and very few persons had to stop DTG basically because of side effects. Also, the DTG containing regimen over 96 weeks, there were no resistance to the drugs and no mutations were found basically. There have been some issues which have come up repeatedly, basically on the weight gain and certain drug-drug interaction, which have already been dealt, but we'll be just highlighting them towards the end again. But DTG-containing regimen are the preferred first-line treatment for all HIV-positive adults initiating treatment or on treatment, and these are being transitioned over time by NACO. And I'm told that almost 80% of the PLHIV now are on DTG-containing regimen. So basically, we all know that we use a triple drug combination, and the other two drugs come from NRTI backbone, which could be preferably a non-thymidine, that is tenofovir and lamivudine, and one INSTI, preferably DTG. So the NACO guidelines, based on the evidence supporting better efficacy, fewer side effects, prefer first-line regimen for all PLHIV age more than 10 years, weight more than 30 kg, is using a fixed dose combination, emphasizing on fixed dose combination of tenofovir 300 milligram, lamivudine 300 milligram, and dolutegravir 50 milligram at any fixed time every day as per patient's convenience. It is unlike efavirenz, which had to be given at bedtime basically because of potential CNS side effects like vivid dreams, hallucinations, and all. But DTG basically, in some patient, it may cause little insomnia, but otherwise this can be given at any time that is suitable. But it has to be a fixed time, almost 12 hours, almost 24 hours at the same time. That is important point. We have also learned this in the last session, basically session on ART, that once a person is started on antiretroviral therapy, of course, with adequate adherence, there was a lot of focus on adherence in one of the previous sessions, and we all know the importance of adherence, maintaining high levels of adherence. So once a person is started on antiretroviral therapy, basically on every visit, which may be a monthly visit or which may be a once in 3 months, depending on the dispensing guidelines at that time, have to be monitored with the body weight for children, height and length. Treatment adherence has to be monitored at every time. Clinical staging, T-staging, and also 4-symptom screening. We know the importance of this 4-symptom TB screen, that this has to be done on every visit, and also laboratory evaluation for which guidelines have already been shared. As far as CD4 count is concerned, basically CD4 count has to be done at every 6 months. But as the program has now rolled out viral load monitoring, and once a person is virologically suppressed, the CD4 count can be discontinued, except for those who are HIV2, because the viral load is available only for HIV1 and not for HIV2. So when CD4 count is more than 350 and virological suppression is there, which means viral load copies are less than 1000 copies per ml, then we can stop CD4 monitoring. An important point to note here is that both tests should have been done at the same time and not at the different time. But CD4 monitoring has to be restarted for any patient, basically who has been switched due to treatment failure or if deemed necessary for clinical management at any point. And for patient on second and third line, viral load monitoring has to be done every 6 months. We'll go into more details on this. So what do we expect when we start a person on antiretroviral therapy with good adherence? Basically, we expect that person will have a virological suppression, and then that will lead to an increase in the CD4 count and a clinical response. So we always look for a response after at least 6 months after initiation of ART. And after 6 months after initiation of ART, though we know that DTG will be able to suppress it in 4 weeks, but for all practical purposes, any response is assessed after 6 months after initiation of ART. And then it should be a viral load of less than 1000 copies per ml. And this should remain either undetectable or less than 1000 copies, depending on the test being employed. And once the person has responded in terms of viral suppression, naturally the immune due to immune restoration, CD4 count should increase. And generally it is seen that this increase is almost 50 to 100 cells within 6 to 12 months of ART initiation in persons who are ARV naive. So in terms of clinical response, as I said, this has to be evaluated every visit in terms of weight gain, in terms of general well-being, and in terms of any adverse reaction to drugs, and also looking for iris. So that was a brief recap about the first line treatment and the response to the first line treatment. So let us see what do we mean by basically treatment failure and when should we suspect the treatment failure. As I said, basically we should only be talking about treatment failure after 6 months of therapy. And this is indicated by any new opportunistic infection, recurrence of opportunistic infection, a clinical event after 6 months on antiretroviral therapy, or a progressive decline in CD4 count, unsuppressed viral load, which is more than 1,000 copies, or if a person shows no clinical improvement over 6 to 12 months associated with stationary CD4 count, despite good adherence. All this suspicion should arise after taking into consideration the levels of adherence of the person. So it is most important that if we want to keep the person on first line therapy, which is the simplest and most durable treatment, we need to ensure a good level of adherence. It's not moving.
So please click on the slide and then click next.
Yeah, okay. So how do we define basically treatment failure? Treatment failure definition is very clear. As I said, virological failure is basically defined as plasma viral load of more than 1,000 copies per ml, and individual must have been taking ART for at least 6 months before we say that there is a treatment failure. In terms of immunological failure, basically first we have to rule out any concomitant or recent infection. Even a simple viral infection can cause a transient decline in CD4 count. So basically any CD4 count which is 250 cells following a clinical failure, or a persistent CD4 count below 100. Some guidelines say it should be below 50 after 12 months on IRT to be more appropriate, but below 100 at 6 months is immunological failure. And any new or recurrent clinical event indicating severe immune deficiency, either a WHO stage 4 condition, is a clinical failure. And this condition has to be differentiated from iris. We know that after initiation of antiretroviral therapy, particularly when the initiated at CD4 count, which is lower on the lower side, the person gets what is called as iris, and we can differentiate with iris basically based on the rising CD4 count. When we say clinical failure, certain WHO clinical stage 4 conditions, which are like lymph node TB, uncomplicated TB pleural disease, may not indicate a treatment failure. And sometimes even stage 3 condition like pulmonary tuberculosis or severe bacterial infection may indicate a treatment failure. This is just to show you chronological infection, and you are very well aware with this, that a person starts failing, then there is an increase in the viral replication. So you can detect the virus beyond 1,000 copies at that time. And then there is a decline in the CD4 count followed by a clinical detection. But the average time between a treatment failure to initiation or early onset of the treatment failure to a clinical detection may vary between 1 to 2 years. So it is important that person who has failed should be switched to the second line therapy in timely manner. So it is important that we should be doing a viral load on a defined regular interval. And this is to show what is the timing of the viral load. We know that viral load is the preferred monitoring to assess response to ART, to identify and confirm treatment failure. And now this is available across all ART centers. So timing is persons who are on first line antiretroviral therapy. First viral load testing should be done at 6 months, at 12 months after initiation of ART, and then annually once the person is suppressed. It is important to note that we do not require a viral load testing at baseline. There is no such recommendation from NACO or WHO, and they should be, first test should be only at the 6 months. But persons who are already on second line ART, it should be done every 6 months. These are the broad guidelines, but in addition, for all who have PLHIV who have been transitioned from their earlier regimen, which was non-DTG based regimen, or they have been switched from first line to second line. This should be done at 6 months, 12 months, and then annually for on first line, those who have been substituted, but every 6 months for second line. Just to mention by side that when we do viral load testing for HIV positive pregnant women, this is to determine the risk of transmission to the baby. And this is to be done at 32 to 36 weeks of pregnancy, regardless of duration of ART, whatever time she started antiretroviral therapy. So this is just a repetition to emphasize that this viral load is available only for HIV-1. More than 1,000 copies basically will be a virological failure if the adherence is more than 95% with 3 months step-up adherence. So we'll see what is step-up adherence. But before this is just to show you the algorithm. If you conduct a viral load at the scheduled duration, it is less than 1,000, continue same ART and routine monitoring test. If it's more than 1,000, basically counselor has to provide a step adherence counseling package to the person for 3 months. And only when there is a adherence of more than 95%, 3 months, a second viral load should be conducted. If that adherence is not adequate, this should again be continued. This step-up counseling for adherence should be continued. If in the second viral load, the viral load is less than 1,000 copies, continue same treatment. But if it is more than 1,000 copies, then e-referral should be made to SACEP. So what are the factors that needs to be considered when we are defining the treatment failure? It is treatment adherence. It is a detailed assessment of adherence to be made. We know that from our experience that treatment adherence is not monitored adequately for various reasons. We have seen the cards mentioning more than 95% when it is actually not more than 95%. This has been discovered in SACEP reviews and field visits. So it is very important that detailed assessment of adherence needs to be done. Also, we also have to see what are the reasons for non-adherence. Whether person is not able to come regularly, he has got issues with transport, he has got issues with his job timings. What are the reasons that he's finding it difficult? Or it is a drug-drug interaction. There may be some taking some herbal treatment that might be basically leading to lower bioavailability of the antiretroviral treatment. So that could also be a reason for treatment failure. So in addition to adherence, we have to see for drug-drug interactions. Very important when we say DTG, basically we have to see that he is not taking any multivitamin with the DTG. What is the dose of metformin that he is taking? Though it is more for metformin and dose that needs to be reduced. He may be taking some antacid, which has got aluminum, magnesium. So we have to look into those reasons that may lead to reduced bioavailability of the antiretroviral drugs. And also certain opportunistic infection, occult malignancies can lead to decline in CD4 count. You have also to look for hepatitis B infection if that has not been looked for earlier. So to summarize, compared to clinical or immunological monitoring, viral load monitoring is preferable because it provides an early indication of treatment failure that is more accurate. It is important to identify the cause of the failure, which could be reasons as I mentioned earlier. And before switching, if a person is failing, detailed investigation into ART adherence to be made and drug-drug interaction need to be looked into. So how do we manage a person with unsuppressed viral load? When viral load test is made available, a line list of PLHIV with unsuppressed viral load should be generated on daily basis. These are some of the operational issues which I am combining with the technical guidelines, but these are very important. List should be shared with the counselor who is delivering services, and they should provide intensive support to improvement treatment adherence. And this should have at least 3 sessions, which can be spread over 15 days, 1 month as recommended, and depending on the patient's own understanding of the importance of adherence. But it is important that all these sessions are taken by the same counselor for the same patient so that she acts more as a case manager rather than just looking into adherence to ensure consistency, continuity, documentation, and should be done preferably with the person visiting ART center to collect the medication. And meanwhile, same treatment needs to be continued. In case PLHIV is not able to come to ART center and is on multi-month dispensing, 3 sessions can be done telephonically with proper documentation in the step-up counseling form. It is very important that person's spouse, partner, they are also included in this step-up counseling, because particularly important for children, that importance of involving parents is critical. And then repeat viral load testing should be done once the adherence is more than 95%. And I will emphasize this adherence should be calculated correctly to be more than 95%, because we don't want to switch the patient earlier to a second line regimen. And for some of them, that may be their only regimen available if they have used other drugs in the first line treatment or multi-NRT exposed people. So meanwhile, we should also get appropriate baseline investigation done, so that if we have to switch them to another regimen, this should not delay the referral, because we need to send those investigations with the referral. And if viral load count is more than 1,000 copies, an e-referral should be made to SACEP within 2 days of receiving viral report, even if patient has not come. And this SACEP should review the case and share recommendations with the ART centers. This is a ready reckoner. For the sessions that 3 adherence sessions that step-up counseling is required. And if you look at these 3 sessions, they are actually focusing on assessing adherence, reasons for non-adherence, patient's understanding of ART adherence. Does patient understand what is the importance of viral load? Why should they adhere to therapy? And what would happen if they are not adhering to the therapy? And then basically assess what is the support system, who is taking care of the patient's medication, what are the barriers. It could be a side effect to the drugs, it could be depression, patient may have certain addictions. It may be timings are not suiting and he's taking drugs at different times of the day. And there are some issues related to mental health issues also. We also need to motivate patient to stay alive, stay healthy, and discuss with patient and develop an adherence plans basically based on identifying that issues. And also remind them about their next appointment and when the viral load will be repeated. On the second session, assess the adherence since last visit has improved. Yes, you have to appreciate the person if it is improved, definitely, and review if it is not implemented. What were the acceptance between patient and the counselor that they will do these activities to improve adherence. Discuss any new obstacles. Certain new situation might have changed. So modify the adherence plan according to what is new in their situation, and remind about the next due date. Similarly, on third session, again, appreciate the patient if he has improved adherence. If he has not, again, look into where are we lacking, because this adherence is not basically counseling the patient. You have to come to a mutually agreeable adherence plan to which the patient is able to stick and agrees to adhere to. And once you have done these 3 sessions, only if it is more than 95% in each of last 3 sessions, 3 months, it's not really 3 months, it is 3 sessions, which may spread over 15 days to 1 month, even to 3 months, depending on person's acceptance, understanding, but we should try to expedite this so that person is not on the failing for a long time. Then plan a repeat viral load test. If it is not adequate, as I said earlier, basically you have to repeat these sessions of adherence with the person. There is no point in switching a patient who is not adhering to his current regimen. So if viral load count is less than 1,000, appreciate and advise them to continue current regimen and do viral load as scheduled as per guideline, which is 6-monthly guideline. More than 1,000, make a SACEP referral, as I said, within 2 days, and then SACEP should review the case and ask the patient to come to ART center with whom the results can be shared and what are the recommendations of the person. So I think we have gone through this basically, but this is basically the SACEP protocol. When a person is being referred to SACEP, what information is required while referring in the RRF form. You have been doing this for quite some time. I will not go into details, rather move on to the regimen. So the SACEP coordinator will facilitate this consultation, which may be a teleconsultation, and review the documents, and then they will inform the ART center on the regimen. So now, once we have confirmed the treatment failure, let us see what we mean by what is a substitution switch and what do we mean by first line, second line, third line ART. This is very basic. you all know this. There is no clear demarcation basically on the regimens, but this is a kind of operational guidance that a person's regimen, which is his initial regimen prescribed when he was ART naive, that is the first line regimen for that patient. And once a person fails on that initial regimen, which is his first line ART, and then he is basically switched to another therapy after this first regimen has failed, is called second line ART. And third line is again the subsequent regimen used in sequence immediately after second line therapy has failed. So the drug used in these may be different, but largely when we say ART naive patient, we start them on tenofovir, lamivudine, dolutegravir, as I said. So most patient first line ART will now be a TDF3DC DTG based regimen. So what is the difference between substitution and switch? Substitution is basically when you are replacing one of the regimen, one of the drug in the regimen, because there have been some adverse effect to that drug, or there has been some drug-drug interaction. But you are only substituting the offending agent. Person has not failed on the treatment. But if a person has failed on the treatment, this is because of the loss of the efficacy of the drugs he is taking, then we have to change all the drugs, and that is called as basically a switch to a second line therapy. I think we have gone through this, when to suspect the treatment failure. So what are the steps in initiating second line therapy? Basically, we have to define the treatment failure, which we have now covered, that we have undergone viral load testing, and if it was more than 1,000, 3 adherence counseling have been done, and now there is evidence that the person is failing on the treatment. So we have to see what would be the new regimen. So while constructing the new regimen, we have to decide on their NRTI and what to add to that NRTI, whether we have to use an integrase inhibitor or protease inhibitors. So while deciding on NRTI component, basically, if we have used iduvudine in the first line, the choice will be tenofovir. If tenofovir or abacavir has been used in first line, the choice could be AZT unless contraindicated because of low hemoglobin or some other reason. But lamivudine is continued in the new regimen also in the second line, because lamivudine associated resistance mutation reduce the viral fitness and must be a part of second line ART. So once we have decided the nucleoside component of the second line regimen, we have to move to the third drug, and that is basically if person has failed on NNRTI, that is efavirenz or nevirapine, then we have to use a INSTI, but is basically dolutegravir is the preferred regimen. We know that is the preferred regimen over eltegravir, and this is the preferred drug that we have been recommending. For person who had used integrase inhibitor in the first line, then we have to give a boosted protease inhibitor in the combination. The preferred boosted protease inhibitor is atazanavir, ritonavir for various reasons, which include less, a more friendly lipid profile, lesser number of tablets, that is just one tablet compared to lopinavir, but for reasons of better efficacy and issues related to cholestatic hyperbilirubinemia, lopinavir, ritonavir is the drug of choice in pregnant women, or for HIV too, because the efficacy is more. And once you have decided on the regimen, basically, we have to include counseling for adherence because the drugs have changed, patient's understanding have changed. We have to explain the patient about the side effects of the new drugs. What are the drugs? Because there may be more than one pill in that combination. So how to take, what time to take, what are the side effects, and when to report back. So that tailored counseling has to be done basically on the new regimen. This is just to share some of the mutations that are possible with different antiretroviral drugs, but I don't think I would like to go into details of this. We know that some of the mutations like M184V, which happens with the 3TC, that is lamivudine, may be rather helpful, as I said earlier. And then we have got different type of mutations. But since we are not doing drug resistance testing as a routine, now NACO has said that it can be done in exceptional circumstances by Center of Excellence, but since it is not a part of the program, I will not go into these details. What are the resistance mutations? So coming to the crux of the talk and the last 3 slides, basically let us see, and I will go a little slowly here for understanding. What is our failing first line regimen? If it is a tenofovir, lamivudine, efavirenz, or nevirapine, or abacavir, that is basically, that has been the regimen so far till 2020, when DTG was brought in, and in 21, when basically patients on other regimen were also transitioned to DTG. So if a person has been on tenofovir, abacavir with lamivudine, efavirenz, nevirapine, the regimen further second line will depend on hemoglobin levels. Because the regimen NRTI in this will be zidovudine. And we know that zidovudine cannot be used if hemoglobin is less than 9 or there is a history of zidovudine-induced anemia, which is documented. Not only anemia, but documented zidovudine-induced anemia, we cannot use zidovudine. So if hemoglobin is more than 9, our regimen is pretty simple, use zidovudine, lamivudine. This will be in BD dosage with dolutegravir 50 milligram OD. So it is very important to understand now that a person who was on single pill is now being shifted to 3 pills. So that is why I said counseling will be different and should be tailored accordingly. But if hemoglobin is less than 9 or there is a history of zidovudine-induced anemia, the person will go to atezanavir, ritonavir 300, 100 once daily with dolutegravir 50 plus existing NRTI backbone to be continued for the person, unless there is a contraindication to that. So I hope that is clear. But there could be a situation where person was on zidovudine, lamivudine, efavirenz, nevirapine. So we'll just be changing this regimen to a tenofovir based lamivudine with dolutegravir. And if this is available as a fixed dose combination, but if there is a contraindication to tenofovir, then abacavir can be used. We know there are situations when we'll have persons with multi-NRTI exposed with lamivudine, efavirenz, nevirapine, then our regimen will again be basically using a protease inhibitor, which will be atezanavir, ritonavir with dolutegravir 50 milligram with existing NRTI backbone. And if person is co-infected with HBV, TDF has to be maintained. And if there is a contraindication to that TDF also, then entecavir has to be provided. Just to emphasize again, all these situations, if person is co-infected with TB and is on rifampicin-based treatment, which is the preferred treatment for TB, then the dose of DTG has to be increased to twice a day. And this twice a day dosage has to continue for 2 weeks after completion of the treatment. And then it has to be brought down to once daily dosage. Again, as I said earlier, for pregnant women, for HIV-2 or HIV-1 and 2 co-infections, instead of using atezanavir, ritonavir, the preferred protease inhibitor is lopinavir, ritonavir. I hope this is clear, but we can take up questions if something is missing. So coming to failing first-line regimen, which is based on protease inhibitors. So both the person already has protease inhibitors in the first line. This may be with tenofovir, abacavir, lamivudine, and this could be a protease inhibitor, which is either atezanavir or lopinavir. So what do we do? It is much simpler. Similarly, we will change the protease inhibitor to a DTG-based regimen. But for the NRTI backbone, again, the guidance is same. Hemoglobin more than 9, use zidovudine, lamivudine. Hemoglobin less than 9 is the situation. Because we have already used tenofovir or abacavir, hemoglobin is less than 9 or there is history of zidovudine-induced anemia, we cannot use zidovudine. So the person will have a darunavir, ritonavir, BD dosage with dolutegravir regimen in once daily dosage. So, and existing NRTA backbone will continue. So this is the importance when I am emphasizing again about the adherence, because now the person will have how many drugs? If he has already been on tenofovir, abacavir, lamivudine, atezanavir, he was on 2 tablets. Here he was on 5 tablets. Now he will be on 2, 2, 4, and 5 tablets plus existing NRTA backbone. So re-emphasizing back to first line. I always emphasize this. First line is the best regimen for the patient, for the doctors to continue patients on a suppressive therapy. They should focus on adherence. Otherwise, patient is in difficulty, program is in difficulty, you are in difficulty, and a little care stitch in time saves 9, as it is said. So if you are taking care of adherence in the beginning, the patient is saved of many unnecessary switches. Again, if person has zidovudine-based regimen, we shift to tenofovir lamivudine. From PI regime-based first line, we change to DTG, and if there is a contraindication to TDF, abacavir. Similarly, if multi-INRT exposed, there is no other option, but we go to darunavir, ritonavir, BD dosage, 600 milligram BD, 100 milligram BD, DTG 50 milligram BD, and maintain existing. Again, same, if the person has got TB, DTG dose has to be increased to twice daily for 2 weeks until completion. And again, the preferred PIs for those with HIV-2, HIV-1 and 2, and pregnant women and toxicity to ATVR is lopinavir, ritonavir. So coming to a situation which now will come in coming time, coming few years. Again, I said few years because I am hopeful that adherence will be taken care of. A person who is on tenofovir or abacavir, lamivudine, DTG, which is now the preferred regimen, if a person is failing on that, then we go back to our same guidance, hemoglobin more than 9 or less than 9. More than 9, NRTI component is definitely ZL, zidovudine, lamivudine, with a PI being brought in now. If it is less than 9 grams, basically, then we have to bring in atazanavir, ritonavir, of course, but DTG here will be double dose. Any person who has been exposed to DTG and is failing on DTG, I'm emphasizing, is exposed to DTG, failing on DTG, the dose has to be twice daily for DTG. And if a person is failing on zidovudine, lamivudine, dolutegravir, we are going to tenofovir, lamivudine with atazanavir, ritonavir, with a caveat again that lopinavir, ritonavir can be used in, should be used in HIV-2, 1 and 2, pregnant women and toxicity. So coming back after all this, our aim is basically to use one new NRTI. AZT change to TDF, TDF change to AZT. Lamivudine remains there. PI or NNRTI change to DTG, and DTG failing change to a PI. But if AZT cannot be used, then you have to use basically different regimen, and multi-NRTI exposed, basically you have to use darunavir, ritonavir with the DTG. Wherever DTG has been used earlier, the dose has to be, earlier and person is failing, dose has to be BD. I think we have emphasized this. Any PLHIV co-infected with TB on rifampicin based will receive double dose up to 2 weeks after completion of TB treatment. Co-infected hepatitis should receive TL if is not on entecavir, or if cannot receive tenofovir now, should be on entecavir. And for pregnant women, HIV-2, HIV-1 and 2, and toxicity to AVR, use lopinavir, ritonavir. Otherwise, ATVR is the preferred PI. So maybe I will stop here and hand over to Dr. Anwar.
Thank you so much, sir. It is always a pleasure to learn from you. And also I thank NACO for this opportunity, especially Dr. Puri. Good afternoon, everyone. So we'll continue with the same flow of the discussion, and we'll talk about the second line failure and third line. And towards the end, we'll also have some repetition about the drug-drug interaction and also the side effects of the ART in very brief. So shall I share my screen?
Okay, I'll stop sharing mine.
Yes, sure.
Yeah.
Thank you. Okay, I hope this is visible.
Yes, sir.
Yes, sir.
Okay, so again, taking from Rewari's discussion about the second line ART, we'll talk about the monitoring of patients on second line ART. Similar to the first line, we are depending on the viral load basically for looking at the response to treatment. And unlike for monitoring of first-line ART, if the patient is on second-line ART, we do viral load once every 6 months to see if the viral load is suppressed. The algorithm which we used it remains same for the switching of the regimen, but the only difference is the frequency of viral load testing, which is done every 6 months. Patients with unsuppressed viral load, they undergo enhanced adherence counseling, as Dr. Rewari explained it very nicely and in great details about the steps of enhanced adherence counseling, how it needs to be done and what needs to be covered. It doesn't essentially mean that we need to do one session per month for 3 consecutive months, but obviously, depending on the patient and requirement of the patient, we do the sessions with the patient once in 15 days or maybe weekly sessions if required. But the point is that when we decide to switch the patient on the next line of treatment, the patient's adherence should be more than 95% in the last 3 months consecutively in each of the individual months. And then once we are sure that the patient is maintaining the good adherence to treatment, then viral load is repeated, and then we decide to take the next decisions. So Rewari sir again stressed a lot on the adherence and importance of adherence, why it is so important to make sure that patient is maintaining the adherence while we are doing viral load, because a patient, if he is not adherent to one line of treatment, will not be adherent to the next line of treatment, even if we change. Sometimes it is really difficult for the counselors to explain this to the patient, because the current treatment won't be working, and if on paper it is more than 95%, it is difficult to convince people. But of course, it is really important, and that need to be stressed upon all the time. So all those cases who are showing in spite of good adherence, if they are showing viral load more than or the signs of treatment failure, they should be referred to the ART plus or COE. And if the poor adherence is or major OI is identified, then we need to take all the steps possible to improve the adherence. Close monitoring of the patients need to be done. If no improvement is seen after 3 months, then the case should be referred to the COE or ART plus center. Then prescription of the third line treatment can be done by the SACEP at the COE and selected ART plus center. So all your ART center will be linked to certain ART plus center and the COE for this switch and initiation of the third line. So decision for initiation of the third line ART should be taken by the SACEP and the COE at selected ART plus center after the e-review. So after SACEP has reviewed the patient and prescribed the third line ART, the patient's treatment initiation will be done at your own ART center. For initiation, we need not transfer the patient back to the COE or selected ART plus center as we used to do that before or in the past. So the prescription will be given by the SACEP, and the initiation on the third line ART will be done at the ART center itself. This table looks a bit wordy and also a bit complicated, but the basic rules remain same, which Rewari sir has already spoken about. What we are doing here is that we are looking at the previous line of treatment and what patient has already taken in past, and that's the reason history taking really becomes important in case of patients. When we register these patients, history taking in terms of past history of ART in private and including everything, whatever the patient has taken. So in section 4 of the white card, we record all that history. And when we change the line of treatment, we are starting with at least one new NRTI if possible, and one new class of drug. That means if the patient has already received an NRTI, and now we will change the patient to the integrase strand transfer inhibitor in the next line of treatment. So if we are clear about those basic rules of what we are looking at when we formulate the next line of treatment, this table becomes very easy. And when it comes to NRTI, we basically are making two groups of NRTIs here. One group has tenofovir and abacavir in it, and second is zidovudine in it. So based on that, we do all these switches. So the scenarios can be patient who has failed on 2 NRTIs plus NNRTI as first line and now failing on PI-based second line. So the 2 NRTIs can be either zidovudine or stavudine or tenofovir or abacavir plus lamivudine. So these can be any one of these 4 plus lamivudine can be one NRT, 2 NRTIs, and the NNRTI is of course nevirapine Parvez. That is the first line. And when this fails, we obviously, if the patient has taken zidovudine past, we give tenofovir in the second line. 3TC we continue. And as a third drug, we use protease inhibitor. That's how the new class of drug is coming in place of non-nucleoside reverse transcriptase inhibitor. So the failing, so this was the second line for the patient. Now what we do is, because we are actually dealing with only 3 classes in our program, we have this NRTI and NRTI group as one class. Second class, we have this protease inhibitor, and third class, we have the integrase strand transfer inhibitor, in which we have dolutegravir. So in the third line ART for such patients who have been exposed to all these other drugs, we are using a better or higher a drug with higher barrier to resistance in protease inhibitor group, that is darunavir. We give that as a BD dose. So the new class of drug is dolutegravir, DTG OD, and then existing NRTI backbone, which we continue to take the advantage of the remaining effect, because we are not doing genotyping here. So we take the advantage of that. And if the patient is having hepatitis B co-infection, then we also add tenofovir to this combination. So that's how the third line regimen will be made for this patient. Then all the other rows, if you see, like patients who have 2 NRTI and NRTI in first line failed on integrase strand transfer inhibitor as second line, so which is dolutegravir. So if you look at this combination as first line, and again as a second line, you're looking at in place of having third drug as protease inhibitor, here in the second row, we are looking at dolutegravir as second line. So obviously, if such patients fail, we will have new class of drug, that is protease inhibitors, saved for the third line, and in which we are using the best of the protease inhibitor, which is darunavir, BD, and then dolutegravir OD. Sorry, BD is given in this class because, as Rewari sir mentioned before, if the patient has failed and has used, or if we have used dolutegravir in the previous line of treatment, and if you want to use it again, you can use it, but the only condition is that it needs to be given in the BD dose. So that is why here you are seeing dolutegravir 50 mg BD. And as previously mentioned, we also will continue with the existing NRTI backbone in this combination too. Then patients who have had 2 NRTI PI as first line, failed on it, and are on integrase inhibitor second line. So here again, you see PI is given as a first line. Second line, you are seeing dolutegravir. Here also, the same regimen is being used. Dolutegravir is being given as a BD dose because it was used in the second line, and darunavir is given in a BD dose, and along with the existing NRTI backbone. Patient who had 2 NRTI PI as first line, failed on it, and are on an NRTI based second line. So in some cases, we had done this in our program, though it is not a very strong regimen as such, but because we did not have dolutegravir before, that's why we used to do this, that we used to use efavirenz or nevirapine, NNRTI based second line ART. If such regimen fails, obviously we'll give a better in the sense, I'm saying darunavir because it has a better genetic barrier to resistance, which means that virus, it is difficult for the virus to become resistant to this particular drug. That is why darunavir has been reserved for the third line treatment. So dolutegravir 50 mg OD and existing NRTI backbone will be used. Then patient who had 2 NRTI PI as a first line, failed on it, and are on darunavir BD second line. Again, this is possible if the patient has already taken, for example, darunavir or lopinavir in the first line, darunavir in the second line, In third line, we will use dolutegravir as an OD dose because the patient has never taken it before, and then darunavir. So if you focus on the last column, so the regimen looks pretty simple. So all regimen will have darunavir and dolutegravir, but only difference is dolutegravir will be given either OD or BD depending upon if the patient has taken dolutegravir in the past or not. And along with that, we will continue existing NRTI backbone to get that final remaining benefit from that regimen. Because we are not doing genotyping, so we are not sure about it. So this whatever benefit we can obtain, we will continue with this regimen. And if the patient is failing the third line treatment, we'll continue with that that regimen itself, because of whatever combination the patient has, to continue with that combination as like with hope that there will be some benefit. And as Dr. Rewari mentioned, NACO is also looking at that if genotype can be done in selected cases, that also will be the additional benefit. So instead of remembering or trying to remember all this, if people understand the logic, how these formulations are being, or regimens are being formalized or formulated, I think it is easy to then remember. And also focusing on the last column, it is basically one and the same in all cases. So as far as monitoring of second and third line goes, because we are using protease inhibitors and also now darunavir, you can see fasting blood sugar, fasting lipid profile also, in addition to the other routine CBC, LFT, and renal functions. You're seeing viral load, CD4 count. So obviously at baseline, we'll do all. At 3 months, we do the basic LFT, renal function, and CBC. And at 12 months, we do actually fasting blood sugar and lipid profile, because if we are using PI and dolutegravir, at least annually, these tests need to be done to see if there are any toxicities which we are dealing with. As far as viral load is concerned, for all second line and third line, 6 monthly viral load is recommended. For CD4 count, if the CD4 count is more than 350 on ART, and if the patient is on ART, we can stop doing CD4 monitoring of that patient. So we do CD4 6 monthly for the patient with CD4 less than 350. And as I mentioned, if viral load is suppressed, which means viral load less than 1,000 copies per ml, then, and at the same time, as Rewari sir mentioned again, at the same time, if the CD4 is more than 350, then we can stop CD4 monitoring at that point of time. But at any point of time, if the viral load drops below or is above 1,000, we can again restart CD4 monitoring for the patient. And also, treating doctor can request for CD4 and viral load when deemed necessary for clinical management, because we deal with OIs and this temporary suppression of the CD4 also sometimes because of the OIs, minor OIs I'm talking about. So in those cases, if you feel like repeating, and also in borderline cases, if you feel like repeating, you can repeat, but it is better to repeat after 3 months, because before that, even if you repeat the test, it won't mean anything actually. So HIV TB with second line and third line, this I think everyone is aware that because we are using now protease inhibitors since such a long time, we know that if we are using TB treatment containing rifampicin with protease inhibitor, then there are issues with the drug-drug interactions, and that is the reason we don't use rifampicin with the protease inhibitor, because it reduces effectiveness of the standard doses. So rifabutin is a recommended substitution which we need to do in place of rifampicin. So rifabutin containing ART in presence of PI containing ART, if available, without compromising the effect of ART and anti-TB treatment. Both NACO, NACP, and National TB Elimination Program have recommended the substitution of rifampicin with rifabutin for the entire duration of TB treatment. Dosage is 150 milligram OD for PLHIV more than 30 kg for the entire period when ART and ATT are being co-administered. So whenever rifabutin is prescribed, instead of usual FDC package of anti-TB drugs in which we have rifampicin, we'll have to give individual anti-TB drugs to the patient and just replace rifampicin with rifabutin, and rest of the three anti-TB drugs need to be given. Some of the common side effects of rifabutin include orange-brown discoloration of skin tears, or basically body fluid like tears, saliva, sweat, urine, and stool during rifabutin administration. When patients experience chest pain, muscle aches, severe headache, or fatigue, sore throat, these are the signs where additional or further evaluations are required, because these flu-like symptoms and or these things can happen because of rifabutin again. So initiation of PI-based ART when the patient is already on anti-TB treatment, patients need to be, we substitute with rifabutin for 2 weeks prior to the initiation of the second line. And this should be done to allow the hepatic metabolism induced by rifampicin to normalize prior to initiation of PI-containing regimen. So initiation of anti-TB drugs in patients already on PI drug, we substitute rifabutin for rifampicin. For the second line, DTG can be safely co-administered with rifampicin. But the only thing is that if we are giving rifampicin along with DTG, the dose of DTG need to be doubled. And this double dose we use at least for 2 weeks after completion of rifampicin-based anti-TB treatment, after which we'll stop anti-TB treatment of 6 months, and then we continue ART with the single dose of DTG after 2 weeks of completion of ATT. So, so that was about third line ART, and about the management of side effects. This has been dealt with in the previous sessions, so I'll quickly go through this also just for the sake of repetition, and some side effects which are really important to know about. I think those are really important to remember. Like tenofovir, it is usually well tolerated drug because we have now a huge experience of using tenofovir with our patients as a preferred first-line drug. But still, we might have seen the minor side effects like weakness, lack of energy, headache, and diarrhea, vomiting. Most serious side effects can include the renal toxicity, which is induced by tenofovir, and also pancreatitis. It also reduces bone mineral density, so that is another thing to look for if the patient is on tenofovir. For such patients, we need to monitor the renal function as per the NACO protocol, and then symptomatic management from the minor side effect. Calcium supplements can be given if the patient is developing osteoporosis. And also, if you think that patient might develop osteoporosis, you can also recommend the calcium supplements from the beginning. Now, dolutegravir, so I spoke about dolutegravir and all benefits of dolutegravir, which is really great drug and game changer actually. So it may cause insomnia and headache, depression, suicidal ideations, though rare, but still this is something which we need to look for when we are treating our patients with dolutegravir. More or less, generally it is very well tolerated drug. There is again potential for increased risk of neurotube defect, which has been mentioned and discussed about that a lot in many previous sessions, which when we did about dolutegravir. But as we are getting more and more evidence, the drug is looking safe in all categories of patients. So symptomatic treatment need to be done if the patient develop minor side effect, and if we are giving it to women who has pregnancy potential, then all the pros and cons of the treatment need to be explained. Atazanavir, again, we have a huge experience with atazanavir. And one of the important things with atazanavir is that patient might develop indirect hyperbilirubinemia, which is not due to hepatic injury, but it is a physiological jaundice. So this is one thing which we need to explain to the patient right from the beginning when we start ART based on, or atazanavir-based ART to all these patients. Because if we don't, then it will be a huge barrier to resistance, to adherence in future. And it all depends on how the patient understands the importance of ART along with this physiological jaundice for continuation of this treatment. So we'll just have a brief discussion about the management also for the patient in the next few slides. But the other interactions are with antacids. But if you want to give antacid along with atazanavir, so at least 2 hours before or 1 hour after antacids, we need to give the drug so that it doesn't interact with the ART. So lopinavir boosted with ritonavir, again side effect. There are a lot of side effects with this. Again, lopinavir boosted ritonavir. Patient with liver disease such as hepatitis B or C may experience worsening of liver function or liver condition. Small number of patients have experienced severe liver problems with this combination. Symptomatic treatment need to be given for minor side effect and also supportive counseling. We need to explain all this from the beginning because if they have side effect, patients should not, because we say that those side effects are monitoring, for example, nausea, vomiting. We don't care much about these side effects, but for the patients, it might be really serious. They might not be able to eat when this happens to them. So that is why that level of support is really important from the counselors and the ART centers. So that they maintain this treatment along with the supportive treatment to deal with the side effects. And of course, because patients are on this regimen, monitoring of the LFT, lipid profile, and blood sugar need to be done as per the schedule which I mentioned before, which is obviously a NACO schedule. Lamivudine is considered to be very safe drug. We are using in almost all combinations with all patients, almost all patients. And it has very minimal side effects, but patients may feel dizzy and have mild stomach upset, and also may have some throat problems, fever, muscle aches. But we need to acknowledge all these things, and if the patient has any of these, they need to be treated with the symptomatic treatment. Darunavir is a drug which is a sulfa-based drug, sulfonamide moiety. So patient may develop skin reactions, and if not monitored properly, they might go into Stevens-Johnson syndrome or toxic epidermal necrolysis. So it's severe. It can become very serious. So this is a drug which we need to be very careful, especially in the initial months of treatment. It may also cause fat maldistribution and figurative changes in patient's body. So all those things need to be explained and monitored very carefully in the beginning or in the initial few months of treatment, at least. Then symptomatic management for minor side effect, counseling of the patient, and of course, if patient develops Stevens-Johnson's, that is one point where we stop this drug and never re-challenge, because that is grade 4 toxicity. And of course, as this is a PI, we monitor LFT, lipid profile, and blood sugars as per the recommendation. Just quickly, atazanavir-induced unconjugated hyperbilirubinemia. This is most of us are having a great experience with this drug so far. And the only thing to remember is that as this is a physiological jaundice, and it affects the bilirubin, especially unconjugated bilirubin, which increases. But the point is that the enzymes remain normal, ALT, AST, they remain normal. And if they are not raised, we need not worry. And as long as patient is accepting the way we have actually talked about this before, and if the patient does not have any problem with the yellowness which is visible on the skin and eyes, so they can continue with this treatment. They should continue with this treatment because of all the advantages of atazanavir. In terms of management decision, whether to continue, it all depends on, again, patient's willingness and the willingness to tolerate this yellowish discoloration. As I said, this is physiological jaundice. Only thing is that we need to look at the enzymes, ALT, AST. If it is more than 5 to 10 times upper limit of normal, it is grade 3. And if it is more than 10 times upper limit of normal, so normal is 40, and if it is 10 times, it is more than 400, suppose, then it is like red alert. We should not be continuing that after that. It doesn't happen, but if it is because of already compromised liver or other liver issues, then we need to take that decision to discontinue this drug and give the other drugs to the patient. So in case of hepatic insufficiency, dosage adjustment may be recommended. You might have already seen that table where we do the dose adjustments accordingly. Child-Pug score, this is another scoring system which you might have heard before. It is utilized to assess the severity and prognosis of chronic liver disease and to identify patients who require liver transplantation. So this score is to be used only in those HIV-infected subjects who have concomitant chronic liver disease. For example, chronic hepatitis B or C, alcoholism, NASH, and other chronic liver diseases. So dose of atazanavir is 300 and 100 milligram in combination and can only be used in patients with chronic liver disease in Child-Pug class A. But if the patient is in Child-Pug class B or C, you cannot use atazanavir in those patients. I'll not go in details of this table, but this is for your quick reference. So all those patients who are having chronic liver disease, like chronic hepatitis B or C, NASH, and other things, and alcoholic liver disease or cirrhosis. So those patients, if they develop jaundice, and all these things need to be monitored in those patients and classify if the patient is falling in which category of Child-Pug scoring system. So for each of this component, like encephalopathy, ascites, albumin, bilirubin, and total bilirubin and prothrombin time and others, INR. So we give certain points to these patients, and then end of the day we make tally of all these points, and we'll see what is the total score. So grade 1 means mild confusion, anxiety, restlessness. Grade 2 is drowsiness and disorientation, asphyxis. And grade 3 is patient is somnolent but arousable, mild confusion. Grade 3 is coma. So so based on our point calculation, if the total is 5 to 6 point, the patient is class A. In of Child-Pug scoring system, 7 to 9 is class B, and more than 9 points is class 3. So this is and atazanavir can be given only if the patient is class A, which is 5 to 6 points. If the patient is class B and C, atazanavir is contraindicated in those cases. Drug-drug interaction. Now, NACO has actually included few drugs in the guidelines, and those are really important drug-drug interactions where we see in our day-to-day practice at the RT center, and these are very common drugs. Like Rewari sir already mentioned that if the patient is on antacid like aluminum, magnesium, and calcium-based antacids, then dolutegravir should be given at least 2 hours before or 6 hours after the antacid containing these polyvalent components. So also with magnesium, aluminum, iron, calcium, zinc. With this also, which we need to give dolutegravir 2 hours before or 6 hours later. Rifampicin, we already spoke about it, that if you are giving rifampicin along with dolutegravir, you can give, you need to give it in BD dose. Then carbamazepine, if you are using, then also this is another example where we give BD dose of dolutegravir due to drug interaction, carbamazepine. And metformin also Rewari sir mentioned, because we deal with many of the diabetic patients. So if at all patient has to take metformin, the total dose of metformin in a day should not exceed 1 gram in such cases. With the PIs, all these drugs like estimazole, cisapride, fluticasone, we need to avoid concurrent use of them because of potential drug-drug interaction. Rifampicin, again, we mentioned that we need to avoid. Then atorvastatin is again, increased concentration is possible, so we need to monitor the adverse events in those cases. Atazanavir, also we mentioned before that 2 hours before, 1 hour after, if we have to give H2 receptor antagonist like ranitidine or famotidine. So this is just an example that if you are using atazanavir-based treatment along with zidovudine-based treatment, where we actually have to give the BD dose. So we need to make sure that the drug does not is given at the time when we are not giving atazanavir actually. So so these are the few drug interactions which have been mentioned in the NACO guidelines, which are most relevant. But just as a side note, there are so many databases which people use for to check the drug-drug interactions, which are really handy, and there are applications also, phone-based applications also, which people actually use to check the drug-drug interaction. One of the database which I find really helpful is developed by the University of Liverpool. So Liverpool HIV eye chart, I small and chart, Liverpool HIV eye chart. So that is one of the database or mobile application, which is really handy, and you can just check drug interaction for all the ART medications with the common drugs. So it's really helpful to have these guidelines by your side. But if more than this, if you want to check any drug interactions, so those databases or those mobile-based applications will be really helpful, I guess. So that's my last slide. Thank you very much for your patient listening. I once again thank NACO, Dr. Puri, and all like ITech team, and of course Dr. Rewari for giving me this opportunity to be part of this NDLS today. Thank you very much.
Thank you so much, sir. We have a few questions from the chat box. A few of them have already been answered by Rewari, sir. Thank you, sir. Why not use ATVR or lopinavir in third line patients with 2 NRTI and NNRTI first line failure and INSTI-based second line failure, not exposed to PIs at all? I'll just share my screen. Yes, here's this question.
So the question is
Yes.
basically, why not use ATVR or LPVR in third line in patient with 2 NRTI, NRTI first line failure and INSTI based second line failure, not exposed to PI at all?
I think this means that why we are using darunavir, ritonavir, and not using atazanavir or lopinavir in third line for such patients. Yeah,
the darunavir, ritonavir has not been compared head-on with atazanavir, ritonavir, or lopinavir, ritonavir, but it's whatever studies are available in third line with darunavir, ritonavir, along with DTG, have shown a better response. But there has been no head-on comparison as such on with darunavir, ritonavir, or atazanavir. But I will just cross-check that also. In patients taking carbamazepine regularly, no, there is no change of adjustment of dose required for DTG, because the reason for that is dolutegravir is primarily metabolized by UGT1A1 with CYP3A as minor route, and carbamazepine is a potent inducer, but again the dose change is not required as such, except increasing this to DTG to 50 milligram BD, but no change of carbamazepine dose is required. So I'll explain it again. No dosage adjustment for carbamazepine is required, but for DTG we need to increase to 50 milligram twice a day, just as we do with rifampicin. Okay. Hello.
Yes, sir. The next question, is there drug-drug interaction with DTG and phenytoin?
Phenytoin.
One second. So I don't think there is a drug-drug interaction with DTG and phenytoin.
Okay, the next question is transition of ZLD to ZL ATVR, ALD to AL ATVR is temporary due to shortage of DTG availability or going to last?
I think that question answer needs to come from the program.
Okay, sir. So please give me 2 minutes to check the chat box. A patient on DTG and lopinavir has TB rifabutin not available. What to do?
We have to procure single DTG basically, because we need to increase the dose of DTG. If rifabutin is not available, DTG has to be procured.
There's a comment on phenytoin.
One correction. Actually, I just checked in the application, so I didn't know that. So they say that there is a potential interaction with phenytoin and dolutegravir, but it has not been studied. But it is expected to decrease the dolutegravir exposure due to interaction with, as I mentioned about the UGT1A and cytochrome P3 by phenytoin. So there is interaction, and that's the reason. So there are so many drugs. So with each drug, it is difficult to remember, and also it is difficult to have that in the guideline. That's why I think the common drugs. So, and the advantage of having this application is that it is being actually updated every time. So whenever the new drug comes in, you need not actually depend on a document to cross-check, because it will not have, you will not have that drug in the document. So just download that Liverpool HIV eye chart or any other database of interaction you like, but it's really handy and helpful, I guess.
I have also cross-checked in between about phenytoin. This has not shown that the dose of DTG has to be increased. I have just been checking online in the database. Okay, what is the next question?
Kiran sir, can we now give mic access to everyone?
Done, ma'am.
Participants are requested to please unmute themselves and they can ask questions.
Sir, my question was patient on dolutegravir and lopinavir based regimen having co-infected with TB. We can increase dolutegravir to BD dose. But what about lopinavir, ritonavir? It should be super boosted, or it should be rifabutin is not available. So lopinavir, ritonavir part, what to do?
The guidance is very clear: is to super boost with ritonavir. Non-availability of single drugs is an issue which needs to be addressed, even for DTG availability of the 50 milligrams separately. So these are the programmatic issues which I think people from program can answer better.
Sir, actually, there is a lot of intolerance with super boosting of this lopinavir, ritonavir with ritonavir. Patient are not able to tolerate.
Sir, this is Reshu. Can I add here?
Yes, please go ahead.
Yeah, so actually, I think this was discussed in the TRG also, and the toxicity related with super boosting is really very high, and patients really need to be monitored very rigorously. So I think overall TRG did not was not in much favor of like doing a super boosting of ritonavir, but ideally rifabutin should be made available, and NACO had some discussions with the Central TB division whereby I think at the local level the local procurements are to be done. So maybe you can touch base with your DTOs and get the drug. So that is one option. And if at all, if rifabutin is not available, then non-rifampicin regimens may be used.
Thanks, Dr. Reshu, for that. But for non-rifampicin based regimen, rifamycin based regimen, then this will have to be linked to the NTP program, because these may not be available at ART site.
Excuse me, sir.
Yes.
Excuse me, we had a mail that all PR based regimen should be shifted to DTG based regimen if he is diagnosed with TB and rifabutin is not available. Hello? Hello, sir.
Ma'am, we can hear you.
Ma'am, so we had a mail that PR-based regimen is there diagnosed with TB, and if rifabutin is not available, to transition to DTG. Hello?
Reshu ma'am, any comments on this?
Yeah, if a PI can be avoided, that is very good. So
Ma'am.
ideally, like for a PI, it should be substituted with DTG as far as possible. But there would be some patients who would be on DTG plus PI. For those patients, rifabutin would still be required.
Okay, thank you.
Excuse me. My question is, if somebody is failing on second line with atazanavir, itnavir, can we not shift him to lopinavir, itnavir? We should straightway go to darnavir, itnavir.
Yes, if a person is failing on atazanavir, you don't use lopinavir for them.
Now, in that case, we should shift to darnavir, itnavir.
Darunavir with DTG.
But darnavir, itnavir is also a PI.
They don't have cross interaction, drug interaction, unlike atazanavir, lopinavir. They can be shifted to BD dose of darunavir, with DTG.
Okay, sir. Thank you. Sir, if somebody is getting the third line regimen with darnavir, itnavir based regimen,
yeah.
If he has got grade 3 or 4 skin reaction, third line regimen, so what substitute can be done?
For any person who is basically getting grade 3 or 4 toxicity with any drug, you have to stop the offending agent and use another drug. But in this case, we are already on darunavir, and they have failed on atazanavir or other regimen. I think we'll have to stop it and then introduce it again, unless it is a life-threatening toxicity.
Sir, excuse me, pardon?
Whenever there is a toxicity of grade 3 or 4, you have to either stop the offending agent and bring in another agent. But if the person is already on third line regimen using darunavir, and you have already exhausted your regimen of ATVR or LPVR has been exhausted, you have to stop the offending agent and maybe introduce them one. Meanwhile, use DTG 50 milligram twice a day. And there are studies that they can be maintained on DTG 50 milligram BD also.
Is it monotherapy?
Yes, DTG milligram 50 milligram twice daily. But try to reintroduce that drug unless it was a life-threatening toxicity.
Okay, sir. Thank you.
Thank you so much, sir. Kiran, can we have the posters now? The posters is now visible on your screen. Participants are requested to please attempt the posters. Kiran, please confirm, is there a problem with the e-poll?
Praveen sir?
Is there a problem with the post-test e-poll?
No, I don't think so. Two have attempted so far, I guess. Only two.
Kiran, we can end the e-poll now. Or can we have the feedback questions, please? The feedback questions are now visible on your screen. Participants are requested to please attempt the feedback questions. There are 4 questions in all. Kiran, we can end the feedback question e-poll now.
Shweta ma'am, post-test answer is remaining.
Yeah. Kiran, can we launch the post-test again? Is it possible?
No, I think.
Okay.
I've done that.
You have launched it. Okay. Participants are requested to please attempt the post-test. The questions are visible on your screen. Sorry for the technical glitch earlier. In case you have not attempted the post-test earlier, please attempt it now. Kiran, we can end the post-test. Here are the answers to the questions. The following issues should raise suspicion of suspected treatment failure among patients who are on first-line ART for at least 6 months, except the answer is iris. Question 2. Which of the following order is correct regarding the chronology of the treatment failure? The correct answer is virological failure, immunological failure, clinical failure. Question 3. Which of the following statements is true regarding timing of viral load test? The medical officer can request for additional plasma viral load test when deemed necessary for clinical management. Answer to question number 4. Which of the following is true regarding recommended regimen for failing DTG-based first-line ART? All the options are correct. Question number 5. Which of the following ART regimen should be prescribed to PLHIV who had 2 NRTI plus PI as first line, failed on it, NRR INSTI-based second line? The answer is darunavir BD plus DTG 50 BD plus existing NRTI backbone. Thank you, Rewari sir. Thank you, Anwar sir. Thank you, Puri sir, for joining us and for your valuable time. Thank you to all the participants for patient listening. We can close the session now.
Thank you.